Hello, DLD. I'm very happy to be here. So I'm a computer scientist. Naturally, I wanted to talk about AI, but then I saw the lineup and changed strategy. Now I will talk about knee pain instead. I hope this is fine for you. And I will tell you what we do at Medicode and how movement actually tells us a lot about the future and also about pain. Before, let me give you a quick overview of how joint decay usually statistically happens. Age around 35, everything is fine. Peak baseline, peak performance, you're fit, you're strong, your cartilage is intact, nothing is really happening yet. Around your 40s, micro shifts start to happen. Not much, it's asymptomatic, you don't really feel anything, but things are slowly changing. Then, around your 50s, your body starts to compensate. Mostly the joints, cartilage slowly gets damaged, and therefore stiffness and other symptoms occur. And then around your 60s and a little bit later in your late 60s, you have severe, usually, not everyone of course, severe joint damage, cartilage damage, and eventually lots of pain, which then will lead to the inevitable joint replacement surgery or total knee or total hip arthroplasty. I heard the average guest of DLD is around their 50s and 40s, yeah, so don't be frightened, there's still hope. To give you some numbers just to understand the surroundings, around 600 million people worldwide are affected by any kind of osteoarthritis, most of them knee, some of them hip, shoulder, finger, and so on. The total knee replacement market is valued in 2030 up to 11 billion and rising due to demographic changes and due to lifestyle. This number is quite, well, kind of a fun fact. I looked it up several times because I also couldn't believe it, but we have about 5 million sick leave days because of knee osteoarthritis, and then add another 2 or 3 million for hip and another 1 million for shoulder. 5 million. This is impacting our workforce a lot and also pressuring the health system and so on. So if you talk to surgeons, orthopedic surgeons, or if you go through the literature, they're pretty fond of their whole process of knee replacement. This is a sophisticated process. In our hospital, for example, we also do it robot-assisted. It definitely is somewhat sophisticated, but there's a couple of numbers that worry. One number is the unnecessary progression, about 30%. Literature is arguing about this, but about 30% are unnecessary progressions, which means could have been prevented if detected early, if maybe local or a more conservative therapy would have been applied at the right time. The other numbers that are somewhat worrying and interesting, 10 to 20% of people are dissatisfied after knee replacement. While 10 to 20% is quite high already, the more interesting number is, and you have to dig deeper to find it, and we conducted a study ourselves which proves this number, 30 to 50% of people answer neutral. If you're happy with your knee replacement, yes, no, neutral. 30 to 50% are neutral, which raises the question, was major surgery even necessary if after knee surgery they still feel neutral? Let's go back to our timeline. So what's the bottleneck? This is actually pretty easy. We know nothing. At a long time, we simply know nothing. It's a black box. There's no data whatsoever. And it doesn't even really change if you get surgery. Sure, there's an X-ray, and there's another X-ray 6 weeks after surgery, and maybe 6 months, and the CT and whatever. But it's still episodic data. It's not continuous. There's no monitoring in rehab, neither is in prevention. And this, among other things, of course, leads to a care delivery crisis. Patients feel isolated, misinformed, they don't know what's going on, they're frightened. In the end, you won't die from osteoarthritis, but it's still a very, very annoying disease affecting many, many people. It hurts, you cannot go skiing anymore, you cannot play with your grandchildren, whatever it is you like to do. On the other side, we have clinicians, mostly orthopedic surgeons, which are overburdened, overwhelmed. There's more and more documentation. We've heard about this before. There's more and more surgeries. And then they should also have time for patients to explain to them what's going on, which they do not have. The last one is a little bit more on the structural political side. Inpatient rehabilitation, well, it vanishes. I think this is not only in Germany, this is also all over Europe, even the world, which eventually leads to a shift more to Ambulantisierung, as we would say in German, or to shift to home care. But even in home care, someone or something needs to support patients. Telemedicine is a good thing here, or maybe digital apps. And this is exactly what we did in our study group. So I'm still in the university leading a research group. We conducted a clinical study, still are. We called it New Knee. We developed a very easy generic app. What the app does is basically collect data, visualize data, and very superficially explain it. Not too much, because then we would run into medical regulations, but Collecting data, visualizing data. So we started at the beginning of this year. We have more than 400 patients now included. We have zero clinician bottleneck. Clinicians do not have to be involved. Of course, they can be, but the whole process is data privacy conform so that patients can basically do everything by themselves. We have patient feedback loops, so we ask questions, which means we know exactly what patients want and also what they do not want in order to improve in the future. And we have a more or less passive data collection. I will show this on the next slide, but lots of data will be collected passively without the patient doing anything. So what data do we collect? Well, usually in this clinical setup now, patients come to us a couple of weeks or months before surgery, which is usually then the point of time where they do install their app. This is where we start collecting PROMs, patient-related outcome measures. So essentially clinically validated questionnaires about their pain. How severe is it? When do you have pain? About their psychological status, and there's many more. Now the magical thing is we can also collect sensor data, but not only prospectively, but also retrospectively. Why is that? Well, because many of your phones, mostly iPhones, they collect lots of sensor data, gait data, which you can use in a clinical context. And now I'm very glad that I can reference to Ferenc Krauss from his opening speech today, and also Sebastian here on the stage said it before. We're collecting the wrong data at the moment. We're collecting symptomatic data, always data when the patient's already sick. With this approach, we can collect lots of data before the patient is sick, or at least when the patient, sickness is at a lower level. This is how the data looks like. On the left, you can see walking speed. This is just 8 patients, just to give you an insight. On the right is walk asymmetry. So walk asymmetry is maybe a little less intuitive. But essentially, if you look at these parameters separately, which is generally not a good idea, but for the sake of simplicity, let's do it here. If you look at walk asymmetry, the more asymmetric you walk, the less good. Yeah? The healthier you are, the more symmetric your walk is, just to simplify things. So what do we see in those figures? On the left, you can clearly see the physical decline before surgery, and then the red line is the surgery actually. Then you can see the recovery. Patient is speeding up again. And the exact same thing, just the other way around, you can see in walk asymmetry. So patient starts to walk more and more asymmetric, and then after surgery, it gets better. Another thing you can see, patients fail to fully regain the historical levels. Now, while this is kind of obvious because patients also get older, still this is something that many surgeons and also literature claims. After total knee arthroplasty, everything will be perfect. You will be back to normal. Well, not entirely. And one more thing I want to point out is the years of steady, objective structural decay that you can actually see. So in the left figure, you can see 60 months, so 5 years before the surgery happens, before the patient goes to the clinic and says, it hurts so bad, we need to do something. In the sensor data that your phone collected, this is just from smartphones, you can already see the decline. You could have done something. And this is just 2 out of many, many features. I just picked 2. There's much more. And this is not AI yet. This is just plain data collection, data visualization, and looking at it. Yeah, and the same thing again happens on the right with walk asymmetry. Yeah, it's going up years before already. Walk asymmetry starts to increase years before the pain is so severe. So now we have longitudinal data. What can we do with it? On the right is a recent publication of our study group. It was done with a public data set. The UK Biobank is a huge data set. It's not really good. It's not quality data, but it's lots of data, therefore useful in a computer science context. And we were able to detect with machine learning 5 years before knee osteoarthritis, before the clinic actually detected it. Now in our about to be spin-off, what we were planning to do is somewhat related. We want to do early risk flagging. Now there's the context of prevention, telling patients, if you keep going like this, you will end up in surgery soon. Objective pain prediction. We can, with a very high correlation already and very high metrics, predict if you have pain. Although patients are not feeling it yet, we can do this with machine learning. And also here, preventive measurements. We can optimize surgery windows because we know which patients are going to be happy or not with that data. So we can early on, with early data, predict you have a high chance of being happy or not, and therefore then optimize the surgical window. And also we can do trajectory forecasting for your recovery phase. How will it proceed? When will you be back to normal? Will you be back to normal? And many more things, yeah? Just a couple of ideas. So let's go back to the timeline again, or to our patients. What clinical and patient impact do we actually have, potentially? We have the objective longitudinal data. Now we throw AI on it. We can do patient empowerment. We have a medical doctoral thesis currently going on this topic, and patients do feel empowered. The funny thing is, Most patients do not even understand the data. We don't even understand all of the data as clinicians and as scientists. Still, patients see their own data and they feel empowered. That's still a good thing. We can avoid unnecessary interventions. We can extend life expectancies in the context of joints. And we can tackle the gender gap. You can see this in the figures above. Males are affected in earlier years more, and then later females are affected more. But we have very highly individualized data, therefore we can do individualized therapies. And then shift everything to the right, into the future, to a later point in time. And also, we can narrow the surgery window, and therefore also optimize processes. On the other hand, what impact do we have on the socioeconomic and financial status on this side? Well, health insurance expenditures, if we lower costs for surgeries, if we don't need surgeries, if you have surgeries later point, the money side. The clinical overhead, this is not only affecting rehab clinics, but also university hospitals. And the occupational sick leave days, the 5 million I mentioned in the beginning. Yeah? With this, we could also work together with big companies and maybe tackle this. So you could say, well, there's Google, there's Apple, they all can do this. There's other gait analysis, which is true. But look at this figure. No hardware dependency, lots of hardware dependency. On the left, episodic data. On the right, continuous data. There's, for example, Kaya Health. They had a big exit beginning of the year, I think 280 million. This is, of course, hardware independent. This is an app, but it's very episodic. It's only data when you actually do whatever, collect data, make your videos. There's the Viking system, the gold standard in gait analysis. Great system, costs more than 100,000 euros. So it's expensive, it's hardware dependent, and again, it's very episodic. It's just a momentum of your, just a moment of your well, current situation. Then, of course, there's the tech giants. Well, of course, they could do things like that, but I think they don't want to. They're more focusing on the horizontal, on the broad spectrum, on what is cool, what is lifestyle. Knee pain is not sexy. We don't want to be sexy. We're fine with that. Yeah? We want to do hardware agnostic stuff. We want to collect continuous data and then do clinical grade AI. So more on the vertical rather than on the horizontal, as the tech giants are usually doing. So the next couple of steps in our endeavor, we're currently conducting a clinical study, and we'll keep going with that. We're currently in the phase of getting things sorted with the university regarding IP, and then we'll go into fundraising to the end of the year and beginning of next year. The first thing we'll launch is called Study Motion, a product that we will offer to other clinics, other research institutes. When we presented the first ideas and first results at the clinical congresses, lots of people approached us and told us, this is crazy, how can we get your app? We want to do studies with that kind of data. We have no means to collect that kind of data. So we came up with the idea on spreading the tool throughout the research and clinical landscape. This way people can do their studies. And we as a company collect lots of data, even beyond osteoarthritis. And the next thing is we'll launch 3 companion apps, new knee, new hip, and new shoulder. Now, the beauty about this idea, one of the beauties, is that with this approach, we can easily scale into hip and shoulder as well. Sure, there are differences, but for the beginning, it's very, very similar. Thank you for listening. Please remember, your movement knows about the future, a little bit about your future, and well, we are trying to build the infrastructure for it. Thank you.